Today, I would like to present CORMICA trial, coronary microvascular dysfunction management. 50% of patients referred for diagnostic routine coronary angiogram for angina. They reveal no epicardial coronary obstruction. And we take a basket term, INOCA. We take a basket term, INOCA, to identify this group of population. For quite some time, the INOCA used to remain a neglected group, a negative diagnosis, a diagnosis of exclusion, a neglected heterogeneous entity with great physical and mental morbidity, with decreased quality of life, with consumption of a lot of resources. And then CORMICA study came, which decided to emphasize more on coronary function than on coronary anatomy. There is a tendency for a cardiologist, once the epicardial coronary tree is delineated during coronary angiography, we have a tendency not to look farther. But coronary angiogram has a spatial resolution of 0.3 millimeter, and we cannot visualize the resistance arterioles, which are more important for perfusion, especially during exertion. And we have been very much stenotic-centric in the sense that we do not want to consider the vasomotor disturbances, coronary function, and microcirculation. There are basically three reasons for coronary vascular function testing during diagnostic coronary angiogram when we do not find any epicardial coronary stenosis. We should not be that much anatomy-centric, and coronary angiography does not exclude a disorder of coronary vascular function. It is incomplete without specifically assessing coronary vasomotion of the microcirculation. And we should not accept the resignation that INOCA group is a single heterogeneous entity with no further scope of differentiation. Differentiation is possible through further diagnostic testing. Further coronary function testing enables individualized management, and demonstration of coronary microvascular dysfunction or vasospastic angina provides prognostic information. So there is a situation when we look more as into this picture, we look more as a cardiologist, we look more at the anatomy. And once there is no significant epicardial coronary artery obstruction, we have a tendency to throw this group into the safe basket of INOCA. But as a clinician, we have a responsibility to appreciate the complexity of the situation, the variety of the situation, and the contributing factors to ischemia and contributing factors to the symptoms and signs of these patients. Besides the systemic factors and the myocardial factors, there are some coronary factors as well, which may be missed in the routine angiogram, like occult diffuse obstructive coronary artery disease. There may be sometimes we may miss plus ostial stenosis. We have to look at the structural microvascular dysfunction, endothelial impairment, etc. Now, once there is no obstructive coronary artery disease, epicardial, we have got three possibilities now: microvascular angina, vasospastic angina, non-cardiac chest pain, or any combination of first two. And these subgroups, differentiation is important because they have got distinct mechanism of disease, and they have got distinct response to different type of therapy. And demonstration of such mechanism leads also to prognostication, which is very important for the physicians and the patients. And that was the reason behind starting CORMICA study, which was to test stratified medical therapy in identification of this key subgroup of patients within the undifferentiated, hitherto undifferentiated INOCA population. And when this study was contemplated, the practice guidelines recommendation for therapy stood on weakest evidence, level of evidence of C, reflecting a lack of randomized trials. And in clinical practice, adoption of coronary function testing in INOCA group was absolutely mostly zero. There was no evidence that a diagnostic strategy linked to therapy improves patient outcome, and there was definitely a gap of evidence. There was a scope of improving patient outcome in this subset of patients, and that's why a hypothesis was made that stratified medicine guided by an interventional and diagnostic procedure, IDP, which linked medical therapy is routinely feasible, and it improves angina in patients without obstructive CAD. So, CORMICA trial, which was a non-crossover parallel group randomized sham-controlled trial with blinded outcome assessment. The design was that when the patients were referred to two large hospitals in west of Scotland for angina as outpatients, they were screened. They were the settle angina questionnaire was performed on them, and when it was a possible angina or definite angina, consent was taken. They were invited for participation in the study. Once consent was taken, then quality of life questionnaire, treatment satisfaction questionnaire, brief illness perception questionnaire, and physical health questionnaires are also performed. Then these patients were enrolled into the cardiology department, where a physical questionnaire was performed regarding the diagnosis and management strategy by the physicians, and this physical questionnaire was done 3 times, once before angiography, once after angiography before randomization, and once after randomization. And once it was found that there was no significant obstructive coronary artery disease, diameter stenosis less than 50%, or fractional flow rate reserve more than 0.8. And that's, at that point, randomization was done. There were 2 arms. In both the arms, actually, diagnostic, invasive interventional diagnostic procedure was done, but one group was blinded. The other group was treated as per the stratified therapy. And after 6 months, again, that management is done, that evaluation is done. So these are the numbers in the study, and interventional diagnostic procedure adopted was coronary flow reserve, index of microcirculatory resistance. Then this is for microcirculation. Then acetylcholine in incremental dose for microcirculation and bolus dose for epicardial coronary artery. Fractional flow reserve was also done, and these were performed. Then there were different sets of almost similar epicardial coronary artery disease, but in panel 1 there is normal invasive physiology. Then when acetylcholine was performed, acetylcholine test, there was vasospasm. This was labeled as vasospastic angina. The second panel, coronary microvascular dysfunction was detected, and these were treated with beta blockers, lifestyle changes, and ACE inhibitor and statin. A third group, and this was non-cardiac chest pain. So after 6 months, angina was found to be improved, and secondary improvement endpoints were also improved, and there was not much of safety concern. Nowadays we get a 1-year result that is also good. And so after CORMICA, the ESC 2019 guideline has come, the testing for suspected mitral vascular angina using a guidewire-based coronary flow reserve or microvascular resistance is a class 2A level B treatment modality. The treatment should address the mechanism or pathway dysfunction in patients with abnormal CFR or IMR and negative acetylcholine provocation test. Beta blockers, ACE inhibitors, and statins, along with lifestyle changes and weight loss are indicated. Microvascular spasm can also be treated like vasospastic angina. This is the recent COVADIS criteria for diagnosis of patient. And this is basically the algorithm. First, we do the invasive diagnostic procedure. Then we do the acetylcholine test. If everything is normal, it is non-cardiac chest pain. And if the acetylcholine test is positive, when there is CFR is low and IMR is high, then it's microvascular and vasospastic. When the acetylcholine is negative, when FFR is high and CFR is low, this is microvascular angina. Otherwise, it is obstructive CAD. and there are different treatment promising modalities based on the treatment is linked to the diagnosis based on the specific substance has evolved. So in conclusion, CORMICA is the first randomized sham-controlled trial of diagnostic strategy in angina and no obstructive CAD. Adjunctive IDP is routinely safe and visible. Physician diagnosis was found to be changed in half of the patients. And stratified medicine guided by IDP improves health status at 6 months and 12 months. The trial has really opened up the scope of differentiation for INOCA patients, also leading to targeted therapy as per exact pathogenesis in the hitherto undifferentiated neglected group. Trial has opened door for change in guideline-specific algorithm and stratified treatment for INOCA. Thank you very much.